Hi, good morning here in America, good afternoon, rest of the world. On behalf of IFSO, we welcome you to this month Journal Club with a very interesting topic about bariatric surgery in cirrhotic patients, a match control study. And we have here Nico Quesada, who is the leading researcher in this article. And welcome, Nico, and thank you for your time and thank you for being with us here in this Journal Club.
Thank you, Sebastian. Thank you to IFSO organization for allowing us to present our data. I hope you all guys around the world are okay in these hard times with the COVID pandemic. Hopefully you are doing good with your families and relatives, and my heart is to every one of you who are suffering because of this terrible disease. So
Yes.
Go ahead, Seba.
Okay, so let me introduce Dr. Quesada. Dr. Quesada is a bariatric surgeon and an upper GI surgeon from the Digestive Surgery Department from the Pontificia Universidad Católica de Chile. And he will present us his paper about this interesting topic. Just to remind you to the audience, this presentation will be interactive, so you can do some questions in your question area in your application, and if you cannot see this live, it will be recorded and we will post it in the next few days in our virtual academy. So Nico, the microphone is yours, and thank you once again for your time.
Thank you, Seba. So today we're going to talk about this paper about bariatric surgery in patients with cirrhosis. This is a major case control study we did this year. And as introduction, we all know that bariatric surgery is the most effective intervention to treat patients with obesity and most of their comorbidities. But we also know that bariatric surgery offers another benefits, right? So, for example, it prevents or delay the onset of severe comorbidities, okay? It may reduce the occurrence of complications of comorbidities such as microvascular or macrovascular disease. In examples such as diabetes, it achieves a good control and most of the time disease remission, which turns into improved overall survival. But it's also true that it improves organ function once the organ damage has been already established, and that is true for the heart, for the kidney, for the lungs, and the diabetes about what happened with the liver, okay? But importantly, it also improves patient symptoms. You can have a better working heart and then patient will feel better, right? So that is very important for our population. In the case of the liver, it is true that, and it is very well known that as the body mass index increases, the risk of having fatty liver disease and its inflammatory form, the NASH, non-alcoholic steatohepatitis, also increases, right? For a patient who is who have obesity, the rate of having fatty liver disease is between 10 to 20%, but when patients become morbidly obese, this percentage rises, as well as the NASH prevalence. And the main problem with NASH is that we know that some of these patients will develop fibrosis and they evolve to liver cirrhosis, which is currently, at least in Chile and maybe in most of the Western countries, the leading cause of liver cirrhosis and liver transplantation. So this is a big problem that we are facing every day in our clinical practice, okay? The main problem is that some patients seek for bariatric surgery when they already have liver damage, okay? And the big problem is that when they do seek bariatric surgery with liver damage or with liver cirrhosis, they have an 8-fold increase in morbidity. And morbidity and mortality is directly related to the degree of liver dysfunction, as we can measure it by the MELD score or by the child Cook-Turcotte classification. For example, in general surgery, patients with child A cirrhosis have a 10% mortality. Child B increases like to 20, and when you do elective surgery in child C patients, you have higher than 50% mortality. So it is very important to know that these patients have higher mortality and that we are dealing with a population that may have severe problems in the postoperative period, okay? So the aim of our study is to compare the bariatric surgery, the results of bariatric surgery in patients with cirrhosis and to be compared with patients without cirrhosis, okay? We also wanted to compare the medical and surgical morbidity between the groups and between procedures, and to compare the weight loss and comorbidity remission between the patients who underwent bariatric surgery with cirrhosis and those who underwent bariatric surgery without liver cirrhosis. So this is a retrospective analysis. We included all patients with the preoperative and intraoperative diagnosis of liver cirrhosis who underwent bariatric surgery between 2006 to January 2017. It must be known that all of these patients underwent laparoscopic bariatric surgery, not open. We did 1 to 3 control group matched by gender, age, BMI, comorbidities, and type of surgery. It means for each case we have 3 controls, right? So we got the demographics data, clinical data, lab exams, imagings. We analyzed the percentage of total weight loss and related obesity-related comorbidities evolution. All of these data were followed. We report the early and late complications, and those complications were classified using the Clavian-Dindo classification. And we also followed the postoperative hepatic decompensation or complications. It means if we had encephalopathy, ascites, renal failure, gastrointestinal bleeding in the post-op period, but also in the long term. And we also followed if any patient had an hepatocarcinoma or have a liver transplantation. So as you can see here, we had 16 patients with liver cirrhosis, and they were matched with 48 patients, 1 to 3 matching process. As you can see here, the age is equal between groups, no differences. And this is, it must be known that, at least in Chile, the mean age of patients undergoing bariatric surgery is around 35 to 37. So this is a little bit older population. We have 11 females and 5 male patients, and this proportion is kept in the control group. The etiology of cirrhosis was mainly NASH. We have 2 patients with primary biliary cirrhosis and 3 patients with unknown liver cirrhosis, unknown cause. Okay. In the pre-op period, all our patients have had an upper GI endoscopy, and 3 of them had small esophageal varices. And pre-op comorbidities, we have a 25% rate of type 2 diabetes, 45% of hypertension, and 44% of dyslipidemia. And the mean preoperative BMI was 39 for each group, as you can see. And because of the matching process, there were no difference between groups. Okay. We did, and this is probably what is important in our paper. Almost 70% of our patients had a laparoscopic Roux-en-Y, and 30% had a sleeve gastrectomy. Operative time was not different between patients with cirrhosis against liver without cirrhosis, but although there is a tendency to a little bit longer operative time, this is true for the gastric bypass and for the sleeve gastrectomy. Anyway, there were no statistical differences between groups. The length of a stay in hospital was the same between groups, and fortunately, we didn't have any conversion or reoperations in our series. This is a very important result. Here I just try to highlight in red that the percentage of total weight loss at 3, 6, 12, and 24 months after surgery was the same between patients with and without cirrhosis. And as you can see here, at 24 months, both group has lost almost 28% of total weight loss, which is a very good result. As you can see here, this is the curve of the total weight loss at 2 years. But when we divide these results and when we analyze subgroup of patients, you can see that in diamonds that patients with laparoscopic sleeve gastrectomy with cirrhosis, they had like a slower pace of weight loss. However, at 2 years, all the groups had the same result, okay, almost 26 to 28% of total weight loss. And this is probably also an important slide. And first, I want to show you the bottom of the slide. This is the comorbidity remission. And what was very interesting for us is that patients with cirrhosis had a very low rate of hypertension remission, only 14%, against patients without cirrhosis who had a 65% of remission, and this was different between groups. There were no difference in the rate of remission of type 2 diabetes or dyslipidemia. And now in the upper part of the slide, when we analyze the morbidity in these patients, we see that overall morbidity is higher in patients with cirrhosis, 31% versus 6%. But when we analyze the type or the kind of morbidity, we can see that patients with cirrhosis have a higher chance of having severe morbidity defined as Clavien-Dindo higher than 3. Equal or higher than 3. So this is different between groups, right? When we analyzed liver decompensations, we didn't have any liver decompensation in the postoperative period. And as a late complication, we have one patient who had a hepatocellular carcinoma who was transplanted 6 years after bariatric surgery. So intra-abdominal surgery in patients with cirrhosis is a challenge for surgeons. They encompass a group of patients with higher rates of morbidity and mortality. When you face a patient with liver cirrhosis, you know you are dealing with a probably high rate of problems in the post-op period. So we can assess the risk of complications with the MELD and the child score, and it is also studied that the MELD scores can better assess the risk. There is a 1% increase in mortality per each point of MELD score the patient had. For example, if you have a MELD score of 8, then the risk of mortality is 8%. And this is true up to 20 points. After that, it increases 2% per each point. But I'm not sure if you're going to do a bariatric surgery in a patient with a MELD of 18 or 20. It's kind of a child B or child C patient that you would not be happy to do a bariatric surgery in that kind of patients. Anyway, our study supports the feasibility of performing laparoscopic bariatric surgery in patients with cirrhosis, always considering that medical complications may occur. In our series, I forgot to say that in our series, the severe complication, the Clavien-Dindo 3 or higher, was medical complications. It was an acute kidney failure due to dehydration. And we had a patient with a cardiac arrhythmia. Both of them required being in the intensive care unit. But fortunately for us, we didn't have any leak or hemopentryoma or surgical complications that may decompensate the liver status. Our search of the literature showed that most of the published series of bariatric surgery in cirrhotic patients are performed in child A patients, and most of the series increase medical and surgical morbidity, but there is no increase in surgical mortality when these procedures are performed by laparoscopy. Okay. So in our hands, sleeve gastrectomy and gastric bypass offer good outcomes in terms of weight loss and comorbidity remission, except for hypertension. It has to be said that gastric bypass has some problems in this kind of patients. For example, if you do a gastric bypass, you will have exclusion of the gastric fundus. Then, if you have a bleeding from the varicella of the fundus, you will not have endoscopic access to control that bleeding, so that could be a big problem. On the other hand, you have a difficult access to the biliary tree, and if you are having a liver transplantation in the future, you will have a big problem if you have any biliary complication after the transplantation. So it is something that must be considered. There is a concern about drug absorption. I guess that this is most theoretically, but in the practice, you see that patients with other kinds of intestinal diversions, they don't have this immunosuppressant drug malabsorption. So that is more theoretically, but it's something that must be considered as well. And if you think that patients with transplantation in the long term may be users of corticosteroids and aspirin, you will have a higher chance of have marginal ulcers. So those topics must be very well thought and discussed with the patients when you're thinking about doing a gastric bypass in somebody who has a Roux-en-Y or who wants a Roux-en-Y. On the other hand, the sleeve gastrectomy, maybe it offers a better benefit to risk profile. However, if you have a portomesenteric vein thrombosis, which is a complication that is not frequently, but it has a high rate in a sleeve gastrectomy, you may have a very difficult liver transplantation in the future. In fact, this is a relative contraindication for liver transplantation, so it could be a very hard problem. Our research in the literature showed that there are 3 cases. One of them required a liver transplantation because of refractory ascites. One of them had a bowel resection because of bowel ischemia, and the other one had only anticoagulant therapy in the long term. So in our series, we think that, or we show that laparoscopic bariatric surgery in patients with obesity and type A cirrhosis is effective for weight loss and comorbidity improvement, but it carries an increased risk of medical complications. So thank you so much, Sebastian. Go ahead, please.
Thank you, Nico, for your presentation, and congratulations one more time for this amazing paper. Congratulations for you and the rest of your team of researchers. And I have some questions for you about the presentation we just saw. Number one, for me, it's very remarkable that you had no surgical complications in the cirrhosis patients group. But do you have any recommendations for the audience about how to manage in the OR with these kind of patients?
Yeah, I guess that this is not only what you do in the OR for this kind of patients. I mean, these patients should be very, very, very well prepared in the pre-op period. We are very we ask them to have a very good weight loss prior to surgery. 5 to 10% is ideal, and they have to have a very good compensation of other comorbidities. So the preoperative management is very important. Second, when you are in the OR, probably in my opinion, you will not let the resident do any part of the surgery. And I guess that when you're facing a patient that you know that will have more problems in the post-op, you are very focused on the case, and you take care of all the steps that you sometimes do almost automatically. You are very focused on the case. And I guess that the most important part in this surgery is retracting the liver and pulling it up, because this is a hard and heavy liver, and sometimes it's hard to pull it up. We use the Ackerman, this is like a steel stick which pulls up the liver, and I guess that placing this and dealing with a little bit increased size of blood vessels in the stomach may be the challenging step of the surgery. But again, if you're very focused and you are very careful dealing with the tissues and all the stuff, you will not have so much problem.
Perfect. Thank you, Nico. We have a couple of questions from the audience. Dr. Simon Wong like to make you 2 questions. Number 1, what are grade 3 complications about the COVID-19 classifications you divided between in less than 3 and equal or above 3?
Yeah.
Which ones are above 3 or equal above 3?
In our patients, we have two severe complications. One of them was an acute kidney failure due to dehydration. Patient went home and he came back with abnormal values of creatinine and urinary blood urea, and he had the history of not drinking water, and that's it. It was not a liver problem, but this is a very hard patient, a very delicate patient, so we decided to put him in the intensive care unit, intermediate care unit to manage him. And the other patient had in the immediate postoperative period an atrial fibrillation with a very rapid ventricular response, and he needed cardioversion. So we have to move him to the coronary unit, and that is why those are Claviendo equal or greater than 3. As I told you before, fortunately, we didn't have any leak or hemoperitoneum that could, for example, an infection or a bleeding make the liver decompensate very fast. So I guess that it may happen anyway, right? But fortunately, in our service, we didn't see that, and that's very good for our patients.
Thank you, Nico. And also, Dr. Simon Wong asked, which is the different rate of complications between sleeve and gastric bypass, if you have a different rate?
Yeah, in this area, the patient with the atrial fibrillation was the one with the sleeve, and the other one had a Roux-en-Y. Okay, so this is a small study. We cannot say that we cannot compare that kind of complication because there's only 16 patients. But what I would be very concerned in a patient with a sleeve is portal mesenteric vein thrombosis or a leak. In my experience, no matter how you do the sleeve, sometimes you will have a leak, and no matter what you did, and that's the unpleasant part of the sleeve gastrectomy. Sometimes you think that you did it perfect and you have a problem. With the gastric bypass, which is in my opinion a little or a more complex procedure, you always know when you have a problem or when you have a difficult surgery, and you are more aware, or you can predict if you're going to have a problem, and you can deal with that in the OR. But the sleeve is more unpredictable, in my opinion.
I agree. Talking about hepatic decompensation, you mentioned in your paper that it's maybe a must to have a hepatobiliary team in ready for any real severe complication. Talk us about, do you really think this is a must in hospitals trying to perform this type of surgeries?
Not sure if the hepatobiliary surgical team, but for sure the pathologist medical team, for sure, and a very good ICU team too. Not sure if you have a problem with the gastric bypass or with a sleeve, the surgical HPB team will assist you, but for sure the hepatologist will do. As we talked in the previous interview, Seba, we are a center with all the specialties, and we are very used to deal with this kind of patients. In our department, we work as a whole unit, the digestive surgery department. It means HPV, upper GI, colorectal. We are just one team, and if we need support from each other, we have it. And also with the pathologist. But in my opinion, the hepatologist must be aware of these patients and must be in the follow-up of these patients too.
Great, perfect. Another question that come to my mind while I was reading your paper is about it seems that the old paradigm about not doing Roux-en-Y gastric bypass in patients with cirrhosis is kind of removing, but it's a very important part of your paper, talking about those disadvantages that you can have in the future in those patients with gastric bypass. About the theory you talk about drug absorption, accessing the biliary tract, biliary tree, but compare these disadvantages with the risk of GERD in patients with a sleeve. Which criteria you will use to in the future to select patients to go to sleeve or to a Roux-en-Y gastric bypass?
So that's a great question, because let's say first that this is a retrospective study. Then we are looking what we did in the past. Okay, so we analyzed our patients, then we went to the literature and we read about a lot about this. And in my opinion, if you have a patient that will now be a candidate for liver transplantation, you can offer him a Roux-en-Y. But if you have a young patient, no matter if he's diabetic or GERD or whatever, if he has a high chance of having a liver transplantation in the future, maybe the procedure should be a sleeve gastrectomy because of the problem that you already said. So in my opinion, and after reading, doing this paper and reading a lot of papers about this, I think that the sleeve gastrectomy should be the procedure of choice for patients with the liver cirrhosis that have the chance of having a liver transplantation in the future. For example, I was asking yesterday a colleague from the HPV team, when do you not consider a patient for a liver transplantation? And he told me, okay, we have this relative and absolute contraindication, but if you have somebody who is 70 years or older, probably he will never get a liver transplantation here in our country. Then probably that patient will have a Roux-en-Y if he is seeking for improving comorbidities, delaying the progression of liver disease. In my opinion, that is the right indication for the Roux-en-Y. Otherwise, they should undergo a sleeve gastrectomy.
Thank you, Nico. Great. A couple of questions from Dr. Ahmed Bashir. The first one, how do you decide to perform Roux-en-Y versus sleeve? You already answered that question. And which Roux-en-Y configuration did you use in patients with cirrhosis, and if it's different from patients without cirrhosis?
For us, it is a standard Roux-en-Y. This is 50 centimeters biliary limb and 150 centimeters alimentary limb. That's it. It is almost the same for all patients. In our group, we do 2 meters of alimentary limb for patients with BMI over 50, but that is all the modifications we do. The standard blue and white, no other modification.
Perfect. Great. Thank you, Nico. And one last question from the audience. Which patients do you refer as selected patients in this group of child A patients? Do you have any recommendations for surgeons who are having this kind of patients, and which patients in this group of child A you select for more safer surgeries?
I would say that portal hypertension is a condition of risk. Then, in my opinion, child A without portal hypertension are the better candidates to be scheduled for laparoscopic bariatric surgery. If you have a portal hypertension, you have high risk of bleeding problems and probably and technical problems in the OR. So, in my opinion, this child A selected patients should be those without portal hypertension.
Perfect. Great. Any last observations, Nico? Any last words for our colleagues, for surgeons around the world who has these kind of patients? Because fatty liver disease and non-alcoholic hepatic steatosis is right now very prevalent in our population. So as this obesity epidemic continues and grows, these kind of patients will grow also in our population. So any last thoughts, any last recommendation? Because even though you are saying that it's a very small group of patients, there's not so much information well done as yours.
I guess that probably what we should do is make people aware of this problem first. I mean, if you have patients with obesity and fatty liver disease, you have to look for NASH and you have to make the population aware of that. Liver problems will be the leading cause of liver transplantation and liver cirrhosis and all the stuff. I guess that is the first message that all surgeons around the world should take that flag and say, okay, we have to prevent people coming with cirrhosis for bariatric surgery. That's the first message. And second, you have to talk probably with the hepatology team and show them that you can do a safe bariatric surgery in patients with liver damage, and that those patients will have a better prognosis if they do have an important weight loss, and they know that. They know that they have to have weight loss and improve diabetes control and whatsoever. And that's probably the second message. Talk with the people who are in charge of this kind of patients and say, hey, we have an alternative for your patients, and your patients will do good if you prepare them good too, okay? Well too. And third, if you will do bariatric surgery in a patient with cirrhosis, we discussed this with our team, and again, maybe the sleeve gastrectomy should be the option. However, last Monday I saw a patient, a woman, 29 years old, type 2 diabetic, very dyslipidemic, BMI 35, and in my opinion, she's a better candidate for a gastric bypass. However, she already had cirrhosis. Then, in my opinion, she is a better candidate for liver cirrhosis, but sorry, for a gastric bypass. But I know that she probably will get a liver transplantation in the future. So, although I know that maybe diabetes will not have a good control or better control as Roentgen will achieve. Probably for her, the sleep is going to be a better option, because I'm thinking in the liver transplantation in the future. She's a very young woman, right? So for me, at least, it has been like as you said, a changing in the paradigm of the way we usually work. We have to think in the future for these patients. So maybe just to finish, three points: be aware, take the flag, and think in the future of these patients.
Great. Thanks a lot, Nico. One last question, because this just one arrived from Dr. Mohamed Elaji. He wants to ask you if, because this is a retrospective study, any of those patients had a portal hypertension diagnosis?
Pre-op, yes, 3 of them. Post-op, none of them.
Okay.
They are big follow. Just one patient had a liver transplantation due to hepatocarcinoma, but not liver decompensation, and no liver progression.
But about portal hypertension.
Before 3 patients, small esophageal varices, but no big spleens, just small esophageal varices.
So now do you have this information? Did you consider portal hypertension a contraindication for any procedure, or no?
No, but it depends on the degree of portal hypertension, right?
Yes.
If you have a very big spleen, and if you see in the CT scan or in the echo a big umbilical vein, you know that it would be problematic in the OR. I remember a case of a gastric cancer patient that with a very nasty liver cirrhosis. We did a portomesenteric shunt, endoscopic tips. We waited for 3 months, and the patient had a normal postoperative period. It was awesome how the patient improved the portal hypertension, and she underwent a laparoscopic total gastrectomy, which is a higher complex surgery than a bariatric surgery, and the patient did very well. So if you can deal with the portal hypertension in the pre-op, you can do surgery in these patients.
Great. Do you find any relation between this finding and the amount of cirrhosis, or child A equals not so high portal hypertension?
Probably that's the key message. In child A patients, you have a very initial end stage organ disease, so they still have a reserve to tolerate surgery. But as long as you move to B or C or higher MELD, you have a worse liver, and probably they will not tolerate a procedure like this one.
Perfect. Well, Nico, thanks a lot. You really personally, you really give me a lot of information to get to my house and get to my hospital. And your key points for me are excellent: to be aware of this problem, to look for the clinical teams who are responsible for these patients, and as we already know, for kidney transplantation, that it's a very outcome in patients with bariatric surgery. We need to extend this message to the hepatologist, and well, be ready for this kind of patients. So on behalf of IFSO, we thank you for your time. We recommend all our attendees, if they arrive later to this meeting, that this session is recorded, so you can access in our virtual academy in the next few days, and stay in touch for our next journal club in the next month. For all our colleagues, and also to Nico, happy holidays, felices fiestas, and a huge and better 2021, because already 2020 was not that awesome for most of us, and we'll hope to see you the next year with better news, and hope to see you also in our World Congress. Nico, any last words?
Well, thank you so much for IFSO and the organization, and thanks to you, Seba, because this was a great experience. Thank you so much for the opportunity to present our paper. And again, I want to send a big hug to everyone in the world. I hope that you are having a good time with your families. And as you said, probably, I hope that maybe we will meet personally in a future Congress, and let's stop this webinars and the stuff that we are doing a lot, and hopefully we'll have a person-to-person contact in the next future. Thank you so much for the opportunity, Seba, and the IFSO organization.
Once again, thank you, Nico. Thank you, and hope to see you in the next Journal Club. Have a great day, and get well, and stay in your house if you can. If you cannot, take care, please. See you, Nico. Thank you.
So much. Gracias. Bye. Thank you so much.